Right, this afternoon we learned the importance and, of course, the best way to talk to people and to engage people is simply by using "Hello, my name is." So, hello, my name is Lawrence. Welcome to this session. This is the session on International Hospital Federation Award winners. I'm pleased to chair this session. Now, just now you've heard from the winners, from the gold winners, their acceptance speeches. Later on, they will be presenting the projects so that you can learn and share from them. Before we commence, can I remind everyone to put your phone on silent, but you are welcome to tweet throughout the session by using hashtag, that is #, IHF Brisbane 2018. Each of our speakers will present one at a time, and at the end of all the presentations, we will have questions. The first presentation is on Give a Life. Please welcome our first speaker, Dr. Santiago, who is the CEO of Foundation Cardinal Infantile Institute of Cardiology. He's the gold winner of the IHF Bionexo Excellence Award for Corporate Social Responsibility. Dr. Santiago.
Thank you very much. Thanks a lot for being here. As you know, the Children's Heart Foundation Cardiology Institute it's a non-profit institution. It's located in Bogotá, in Colombia, in South America. The Fundación was founded to diagnose and treat underprivileged children with cardiovascular diseases. In 1993, the Cardiology Institute was created to be able to treat cardiovascular patients during their complete life of cycle. It means that we treat also adults. During these years, Fundación has acquired high standards of technological and scientific development, and that places it amongst the best institutions for the treatment of high complexity pathologies. Actually, the institution has 350 beds with 53 medical specialties, emphasizing cardiovascular medicines, neurosciences, transplantations, and pediatrics. And our infrastructure has 80,000 square meters with high standard infrastructure and state-of-the-art technology. I want to say that for entire medical, administrative, and assistance personnel of the Fundación Cardioinfantil, mainly for the work team of our social program, it's a great pride to receive here today this very valuable acknowledgement by the Hospital International Federation. To know that all the work that we have carried out during these years has permitted us to keep the dreams of our founders alive is gratifying. The essence and history of the Cardioinfantil is and has always been our main impulse to continue working in search through the Colombian territory of sick children to save their lives and to give them and their families the hope of life they so much deserve. The social responsibility has and will always be immersed in the Fundación Cardioinfantil. This is the reason why every morning we wake in with the desire to continue contributing to the well-being of the good health of Colombian people. We work at the vanguard of the medical area to have the best scientific resources, the best technology, and to always reach clinical excellence. Proof of this is the recent positions that we hold within the ranking of the best hospitals and clinics that is carried by the magazine American Economia, being known as the 5th best hospital in Latin America and the first hospital in Bogotá. For the past 8 years, our database has been audited by the International Quality Improvement Collaborative for Congenital Heart Disease Institution, which objective is to guide the efforts that improve quality and reduce mortality indexes resulting from congenital heart disease in the third world countries. By implementing these practices and having continuous improvements, the Fundación Cardioinfantil reached a 4.5 index of mortality in 2005, and to date the index is 3.9%. This motivates us to continue optimizing our practices and to reduce any adverse event that emerge when carrying out these procedures. Also, since 2017, we have had our database audited by the World Society for Pediatric and Congenital Heart Surgery. From our institution, we have aimed to change the belief that in the developing countries, vulnerable children have surgery with less resources, are more complicated, and receive low-quality services. We have shown that lives can be saved offering high-quality, free medical attention with high technology, and our social children have been looked after exactly the same manner that those who are covered by medical insurance. The children are the reasons for being. So as a leader institution in cardiovascular medicines, we try to offer the best and the most efficient care to the children with heart diseases in Colombia. We've given surgery or treatment to more than 23,000 children in the country, on which 5,000 as part of the program Gift of Life. We are very proud and have a great satisfaction to have complied with our mission. The impact of that we do represents the hope that we give back to the families of these children and the future that we build as we move on. What's the problem? You know, 8 out of every 1,000 children born with congenital heart diseases. It means that this program is very important since approximately 10,000 children are born each year in Colombia with heart conditions, in which 5,000 are underprivileged and fewer than half can access of high-quality medical treatment. What's happening? In many regions in Colombia, there are no hospitals or clinics that can provide comprehensive treatment for children to identify correct heart problems. How does Gift of Life program work? For this reason, people from the multidisciplinary team of the Fundación, made up of pediatricians and cardiologists, nurses, social workers, and other professionals and volunteers, carried out diagnosis brigades for children without resources traveling through the country to diagnose underprivileged children with cardiovascular problems. Saving lives. Every year, an average of 14 brigades of cardiological diagnoses are performed through the country. As a result, around 200 children with heart diseases are identified. Afterwards, they are transferred at no cost from their hometown to Bogota to Fundación Cardioinfantil, where they receive surgery and any necessary medical attention. Thanks to the support of institutions and allied companies, we have joined our mission. The social program team, Gift of Life, manages to reach the different districts of Colombia to develop the cardiovascular diagnosis campaigns. The logistics are coordinated with each of the local partners. We transfer the children from the program with Avianca, this is our partner, is the sponsor of the Miles Bank program by donating the round-trip tickets for each of the children and their companion to their transfer to Bogota, where Fundación Cardioinfantil is located. After that, they are received in a beautiful house. This is managed by a group of volunteers, the Rotary Club and Damas Rosadas, and private individuals. The lodging and food are offered to the patients and their companions until the child's health is restored. The treatment. When the patient arrives to Fundación for surgery or to receive the treatment to heal his or her heart, medical assessments and laboratory tests are pre-surgical studies are scheduled. The return of his or her hometown and checkups. When the child custodial parent receives the recommendation that must be taken after surgery, the child is ready to return home to his or her family with a stronger beating heart and a second chance of life. The results of 2017 is amazing. We saved more than 200 children, but we usually evaluate more than 3,400 children all over the country. And we invest more than $1.5 million every year. This is in the last 15 years, we have saved more than almost 3,000 children of low-income children with heart disease, who we have transferred from different places in Colombia to our institutions to offer them free medical treatment. But we usually treat more than 700 children per year, including the children that are covered with social security system. Accomplishing our mission to save lives could not be possible without donations. Our institution receives every year from companies and individuals who have believed and continue to believe in what we do. We have more than 100,000 volunteers and donations for this program. Thank you for believing in Fundación Cardioinfantil. Your contributions will help more children to have a second chance for life, and it will support the unstoppable mission of the Fundación Cardioinfantil. When you save a child's heart, you save a good heart. Thank you very much.
Thank you, Dr. Santiago. The next presentation is about value-driven outcome, implementation of data-driven approach to manage utilization of resources and improve quality of care by the University of Utah Health in the United States, the gold winner of the IHF EOH Excellence Award for Leadership and Management in Healthcare. Please welcome our next speaker, Mr. Jeff Young, who is the Associate Director of Advanced Analytics and Visualization. Jeff?
Good afternoon, everybody. Like I said earlier, it really is an honor to present here as the one person who stands on the stage where there's this whole team of people contributing to all of these projects that I'm going to talk about. So a little bit about the University of Utah for those who aren't familiar. We're located in Salt Lake City, Utah, which is a beautiful place. We've got 7 separate hospitals and about 15 community clinics. We're a level 1 trauma center, which in United States speak means we'll take anything that comes in the door, anything and everything. And we see about 1.7 to 2 million annual outpatient visits and about 35,000 discharges a year. So the problem we have been trying to tackle in the project I'm going to present about, which we've internally called value-driven outcomes, originated in this idea that we're all very familiar with, that costs are rising. The cost of care is rising. The cost of pharmaceuticals and supplies are going up. Payment in many cases for us was either staying very flat or going down. So from the perspective of operating a hospital, it's more and more difficult to kind of, provide the same quality of care. And we don't want to sacrifice the quality of care. We need to remain profitable so we can invest in ourselves, we can invest in new facilities, we can invest in equipment and all those things. So there are a lot of potential solutions out there, and I guess I'll tell about the route we went. So like I said, we had a solution that was called value-driven outcomes. And I would like to give a plug that we've had excellent senior leadership that have really been able to break down barriers between different teams in our organization and get everyone working on the same, with the same vision of creating value. So the way we went about trying to tackle these value projects that I'll talk about is really building a data structure. The founding principle was that if we don't have good data around the whole episode of care, so the cost of everything, all our efficiency metrics, all of our quality data, then we don't know where the gaps are. We don't know where we're high performing, low performing, etc. So we built this data structure where we housed all of our data in one easy to use location so that we could do value projects off of that. And that includes all of our data around everything we purchase, our general ledger, our procurement system, every supply, every lab, every pharmaceutical, the cost of that, and then marrying all that data with all of our outcomes data, readmission, mortality, the main ones, as well as a lot of one-off ones that we built specific to groups, bringing that all together so that we know the cost of every encounter and the quality of every encounter. And what we really wanted to do was build transparency around data that we could then report back to physicians, department leaders, and groups. And what we wanted to drive were standard practices around areas of care. So having good data would be the first step to getting a group together of providers and nurses and whoever else and saying, when a patient comes in with this disease, what do we want to happen every single time? What are those steps? And then from a data perspective, we can build transparency around that and we can show what's currently happening. We could take a look at a patient and say, when someone comes in with, a trauma case, these are all the potential outcomes. These are all the places they might go in our system. These are the things that might happen. So what do we want to happen? How can we standardize that? How can we regularly report back to the group to ensure that that's happening? And what kind of checklists or stop points can we build into our system to make sure that the right things are happening? And that goes into point 3, continually measure performance and report back to groups on how they're doing. So I was very pleased when the dental group from Victoria mentioned this transition to value or this emphasis on value, because we really push what we call the value equation, and which is the quality of care and the service divided by the cost is the value. And we use this not just in passing, we really rely on this on every project we do. So any project we're going to do, we're going to ask the question, what is the impact this has on the quality of care? We're not going to do a cost-saving project if we feel like the quality is going to be negatively affected. And then the question that is also very important is, what is the patient experience through this? Sometimes we attain high quality metric value, but the patient experience can be negative. So we get a lot of good data from the system we use, where we send out texts or emails that patients can rate their experience. How was your pain managed? How clean was the facility? How friendly was the staff? Because we want to know all these things. We want to know the gaps are. It's one thing to give good quality. It's another thing if patients don't like us because they have many other options and many other facilities they could go to. So in building a culture of transparency, where we started was around the cost of care. As I mentioned before, speaking about the data, we allocated all our costs to each individual visit because we really wanted to know not what was the average cost of a joint replacement, but what did Mr. Smith's joint replacement cost. And the value of having data at that granular of a level is then you can really see the whole picture. You don't just see the average, you see the outliers. You see cases like these reports where you can compare all the providers that perform a certain service and then see what the difference is, as well as you can look at individual cases. And what this gave us in a lot of these cases that we really, when we went and met with providers and looked at their data, where a lot of these groups are working in silos, and 3 people doing the same thing. Provider A, she's doing it one way, she's using a certain set of supplies, ordering a set of labs. Provider B and C, they're doing it differently. So with transparency around the data, we can start that conversation as to how do we want to do this? What's the optimal way to do this? Being on the data side and not on the provider side, I have zero expertise when it comes to actual clinical care. My background is in economics. Actually, one time I went and sat in on the OR on a case. I got invited by a surgeon, and after about 20 minutes, my legs went all wobbly, and the next thing I knew, I was flat on my back. So patients are probably safer if I keep my distance. But you really need transparency to drive the conversation, because what we can bring into this conversation next is the quality of care. Something I'm sure many of you have heard, I hear it all the time, is I might be more expensive. This is a provider speaking. I might be more expensive, but I deal with much more difficult patients, or my patients are sicker, or we're doing different things. But if we have access to all the data, we can look at that entire picture, and we can look at the acuity, we can look at the age, we can look at all those things and try and get an idea of what the best practice is. So we've called these video projects, and we've tried to tackle them one at a time and provide the correct data, provide someone with good knowledge of the quality metrics as well as the financial metrics, and then work with the clinical team to implement the changes. And these are some of the groups we've worked with and some of the projects we've tackled, such as lab utilization for our hospitalist group. They had a situation where we're an academic system, so we're training a lot of residents, and they felt that the residents probably, because they didn't want to get in trouble or didn't get yelled at, would just order everything and really overutilize the access they had to labs. And so we created regular reporting where then everything that got ordered, the hospitalist would need to explain to the attending provider what their reasoning was, or what the kind of medical reason why they needed that was. As well as doing this, we've done this in probably 24 to 36 different areas and have projects in very different stages. And I would like to talk specifically about a couple of those. So what we produce essentially when we build out these metrics that are important to these groups are scorecards. They could be monthly, it could be something daily or something weekly. It really depends on the need, where we can monitor the performance. So what does your cost look like? And not only what does your cost look like, but if we break that cost down into supplies, labs, labor, what does that look like trending over time? What does that look like compared between the different physicians that work in that area or the different resident groups, as well as showing each individual efficiency or quality metric. So if there is an issue, we can hone in immediately on what that issue is. So I'd like to talk about 2 projects quickly. The first project we started with a few years ago was joint replacement. And what we found was we had maybe 5 surgeons performing joint replacements using 3 different types of implants initially. And this was kind of unknown to them. Like I said, they often work in silos. They have their own relationship with the different supplier of these different joint things, which I'm not going to say is a good thing. It's probably not. So what we could show initially was we were getting vastly different prices for essentially the same quality of care. Someone might use implant A, someone might use implant B, and implant A cost twice the amount of implant B, but we could see that over time there was no difference in the quality of care. So with that information and that transparency around the data, we were able to renegotiate the implant cost and get all the implants to that one cost. And then another big change was the joint surgeons looked back through the data and found that if a patient received a physical therapy consult the same day of their surgery, those patients on average went home almost a full day sooner because they got up, they started to move, they were able to meet that mobility quicker and go home quicker. So they moved to where we would monitor, did this patient get a same-day PT consult, and encouraging patients to get discharged to their home with a physical therapy visit instead of going to a skilled nursing facility where we continually found patients having additional complications. So this resulted in over $2 million annually in savings, and that's been going in perpetuity. The other great thing for the patient is they get home sooner. Our readmission rates have gone down significantly by sending people to home, and really by just standardizing the care, that every time someone comes in for a joint replacement, we want these 8 things to happen. And we can monitor them regularly, and if one of them starts slipping, we can identify it quickly and notify the group.
2 minutes.
Yeah, and intervene. So the last projects I'm gonna mention is this ORCA OR cost accountability. So our surgery group really wanted to build transparency around the cost of supplies in the OR. So we built these reports that we send out monthly to every surgeon that lists all of the surgeries that they performed, the OR cost of the supplies they used in that case, and then a comparison of their peers for similar cases over the last 12 months and themselves for similar cases over the last 12 months. So they quickly, once a month, get this report and they can see, how do I compare to myself? How do I compare to my peers? And we've got other reports not here that also mention and show the quality of care. So we're trying to continually make progress. We were featured a year or so ago in the New York Times for some of our efforts, and really we're just trying to drive value. And we're not only worried about the cost of care, but really what's the quality and what effect does it have on quality. And the more financially responsible we can be, the greater opportunity we have to invest in the quality of care for our patients.
Excellent timing. I've been asked to cut the speakers off when they're not on time, so I was about to come up with a knife. The next presentation is on gestational diabetes, apps and interactive clinician portal, internet-based by Metro South Health, Queensland Health. They are the gold winners of the IHF Awards Excellence Award for Quality and Safety and Patient-Centered Care. I think when the name announced, I heard thunderous applause in the audience, so obviously it must be a very good project. So please welcome our next speaker, Dr. Wendy Dutton. She is the Director of the Ops and Gynes at the Redland Hospital here in Australia. Dr. Dutton.
Thank you. And thanks for the opportunity to be able to talk about this project, and I'd like to thank again the IHF for recognising the work that's gone into this. I think you have to be careful as an obstetrician sometimes when you say, I think I need an app for that, because that's how we got here. To talk about the Mother Gestational Diabetes Mellitus, or GDM for short, because it's much easier to say, app, and the Interactive Clinician Portal, which is an internet-based portal, and that's the bit that makes the app work. This is a project that was done in conjunction with Metro South, the hospital I work at, much smaller hospital than Utah. We do about 2,000 births a year, and it's situated in the southern suburbs of Brisbane. And just to put a little bit of background, GDM is one of the most common medical complications of pregnancy that we deal with. It usually occurs around the 24th to 28th week of pregnancy, so we've only got about 12 to 14 weeks in which to work with women once they're diagnosed. And it's associated with short and long-term risks for both mother and baby, especially if a woman's blood sugar levels are not well controlled. So in essence, even though we talk about the mother, we're actually dealing with 2 patients every time. And we have a problem because the incidence of gestational diabetes is increasing. In Queensland, the incidence rose from 4.9 to 8% between 2006 and 2013. Then, new diagnostic criteria for gestational diabetes were introduced in 2014, and now currently 16% of the women who engage with the maternity services at my hospital are diagnosed with gestational diabetes, which for our service means over 300 women a year, which does put a strain on our resources. And we identified that we had an issue, and it was all about suboptimal systems for sharing health measures. We had the woman with her gestational diabetes, and we have a lot of clinicians who input into her. The problem was none of us could actually communicate that well with each other in regards to that individual woman's health outcomes or her blood sugars. And the reason for that was that the women carried a paper-based diary to record their blood sugars. It was with them, it was with nobody else. We could only see it when they came into clinic. So it was very inconvenient and ineffective. And if they forget to bring them in, you can't see them. I recently had one woman who I never saw her sugars because she never brought a book. I'm hoping that she was doing them. She said she was. But it just means everything then is about suboptimal coordination of care. And if somebody gets the results, it's not easy to communicate them with somebody else. They may come into one email address, but only one person gets them, and it's not easy to share everything. So we thought there must be a better way to do this, which was about the improved care through innovation. So women with GDM record their health measures in the Mother app. And then it can be reviewed and reviewed by everybody at the MDT time using the interactive portal at any time. And they can be discussed at weekly meetings, which allows us to do much more coordinated care in a much more timely manner. If a woman's sugars are not well controlled, we can actually see them much more quickly than our traditional, well, you've been diagnosed, record your sugars and come back in 2 weeks and we'll have a look at them. So it allows us to expedite the services that they need if they're needing medication to control their diabetes. But there's quite a few women who will actually control their diabetes very well by diet alone. And this is a group that will probably be able to decrease their unnecessary clinic visits, because in the time frame from around 28 weeks, we don't need to see everybody 2 weeks, but we're doing it just so we can look at their sugars. So we were lucky enough to be able to collaborate with CSIRO, and Dr. Varnfield's here in the audience today, and she's been a vital part of this all getting up and running. So that mobile health or mHealth solutions that include both web-based and smartphone applications have and are being increasingly used in the management of chronic disease. And so we were able, and CSIRO, they have a platform which is comprised of the app and the web portal, and we called it Mother, and this was developed for use by women with gestational diabetes, and it leveraged off their already validated mHealth program, which has been very successful for cardiac rehabilitation, and it's also now being used for patients on peritoneal dialysis as well, very successfully. So we were able to use this. And basically, what it meant is that the woman can record her sugars in the app on her phone, and we have our age group of women who are pregnant all basically have smartphones, so they can record their sugars. That then uploads to a centralised database, which is then viewable by the clinician through the web portal. So everything is visible to everybody. The app's got a few other useful things as well. They can record some other health measures, such as their weight, and it's got a link to a lot of educational resources as well. So it makes for much better transparency of the woman's health outcomes or blood sugars. And that's just a very basic picture of the app with the health measures and other things, and just a list of some of the resources. It's not a very complex program, but it works really well. And we've had the opportunity thus far to complete a pilot study. The primary outcomes were user adoption and user satisfaction. So would the women use it? Would they actually like using it? And we recruited 40 participants. All these women have now birthed. And our results showed very good levels of satisfaction with adoption of and continued use of the app. Overall, 96% of women were satisfied. There was only one woman who wasn't satisfied, and that's because she had connectivity issues. And we did go through a period around Christmas last year where we did have some connectivity issues. But 100% agreed that it was helpful in recording their blood sugar levels and that it helped them to feel confident in managing their gestational diabetes. So it actually had real benefits for the women. They also said that it was convenient. They've got their phone everywhere. They don't have to remember to take their book. It was easy to use, and it was all about it being accessible, easily accessible to them, easily accessible, their results to the clinicians. All the clinicians also found that the app, or the interactive portal, was easy to use and assisted in the management of women with gestational diabetes. Everybody preferred it to the old paper book. And we did ask some women, they said we could now have a burn the book session. And all agreed that it provided for more effective and more efficient care of women with gestational diabetes. So the pilot study has confirmed that this technology works for women with gestational diabetes, and as part of the study we asked women to say what would make it better, and we've responded to that, and some enhancements have been identified and are being added into the app. And we're now looking at doing a much more widespread implementation trial in continued partnership with CSIRO. At the moment, across all the maternity units in Metro South, which basically encompasses 6,000 births per year in a region south of the Brisbane River. And that equates to over 900 women with gestational diabetes. And it would now be offered to all women as standard when they're diagnosed with gestational diabetes for recording their blood sugars. And then it's hoped that we can show some of those other outcomes, including quicker response times and treatment, hopefully better outcomes for women and their babies overall. And as I said, for that other group of women, especially women who may have some babies at home where it's more difficult to come in, we can actually do this in a more virtual reality type of way rather than them being there in the clinic or not needing to see them so frequently. And it's important to remember that I've talked about Metro South, but there's probably about 10,000 women per year in Queensland that are diagnosed with gestational diabetes. So we are looking at how we can take this further and make it more widespread. Or if we go Australia-wide, it's about 50,000 women in Australia per year are diagnosed with gestational diabetes. So there's a large scope for using this. As I said, I'd like to acknowledge the CSIRO team, especially Marlene Varnfeld. I'd like to acknowledge Liesl Higgins, who was a very important part in running this project, and all the other wonderful staff that I work with at Redland Hospital, all part of our multidisciplinary team for management of gestational diabetes. And finally, I'd like to thank Susan, who's with me here today as well. I think without her wonderful write-up of this project, I may not be standing here, so I thank you as well.
Thank you very much, Dr. Dutton, for your presentation. Obviously, looking at what you got, the apps would be much better than extending the telephone cord. So the final presentation is on value-based healthcare, a new approach to improve oral health outcome by Dental Health Services Victoria. They are the gold winners of the IHF Dr. Kwan Tay Kim Grand Award. Now, they have a very heavyweight team of presenters. So please welcome Dr. So Weiner, who is the board chair. And then we have Ms. Susan McKee, the Executive Director of Value-Based Healthcare Implementation, and Ms. Jacqueline Gibson, who's a Dental Health Service Victoria consumer. So up to you, your team.
Thank you very much. Good afternoon. In health, we are all grappling with similar major challenges. We have ageing populations, increasing rates of chronic disease, rising costs of technology, workforces designed for the last century, and limited funds. We need to find new ways of providing person-centred care that improves the person's life in a cost-effective manner. The board and executive of Dental Health Services Victoria looked at the data for the people who are eligible to receive our care, people on social security benefits. We saw poor access, long waiting lists, poor outcomes, and huge variations in the services provided across the state. And we said we can and must do better for these people. So we went and we talked to all the people who matter in our world. We consulted far and wide with consumers, clinicians, staff, advocacy groups, government departments, in fact anybody who just stood still long enough for us to talk to them. We listened deeply to those generous people, and they gave us 4 very strong strategic themes. Firstly, we must work to improve health outcomes. Secondly, improve the experience for both the people we care for and for those doing the caring, because we know this is linked to better health outcomes. Forgot the technology, sorry about that. Thirdly, be global leaders with our local partners. We can't do this in isolation, so we want to share our ideas and learn from others. And that ranges from our international neighbours to people in the Northern Hemisphere. And locally, we work with over 50 community health centres and hospitals to achieve what we do for the state. Finally, be a great place to work and a great organisation to work with. And let's be honest, we all strive for that in our organisations. So now we had a plan people were proud of. But how should we implement this? I had been fortunate to participate in the Harvard Value-Based Healthcare workshop about 18 months prior to us finalising our strategic plan. And I realised that this may be the vehicle through which we could achieve our plan. The CEO and I had many discussions, and in consultation with the board and the executive, we decided that this was our way forward. 2 years later, we've started the implementation process, and I'll now pass to Sue and Jackie to share more of the journey. Don't forget that one.
Good afternoon. My name is Sue. I must admit up front that I've been in this position for 6 weeks. So the work that you're seeing and hearing about is not mine. I'm just the one that has to actually make it work at the end of the day. So we've been on a long journey, as Zoe said. None of this happened overnight. And as she said, we spoke to a lot of people. We had an original model of care about 6 years ago, which really focused on how do we improve patient outcomes, what's the patient experience, how do we take some of the work that we do in a hospital out to our community, because that's important. So we then wrote a strategic plan around about 2016, and we looked at the model again. So our new model, the next version of it, said that we actually needed the right staff in the right place, doing the right thing at the right time. We looked at it from a community perspective, and we looked at it from a partnership perspective. Then Zoe and the CEO went to Harvard, and they looked at the Porter and Lee model. And it literally talks about how do you actually integrate services, how do you actually look at specific patient groups. And we actually looked at our patient group and said, well, we run dentistry for Victoria. Is that a patient group on its own? And if so, could we actually implement some of the values of the value-based healthcare model to enable us to improve health outcomes for our patients, which we did. So we actually looked at this model, and we came up with version 3 of our value-based model of care. So it not only looked at how do we actually improve the care that we're delivering, it looked at all the enablers of that as well. It put consumers in the middle, it talked about engagement, and it talked about co-design. We looked at some of the additional things that we thought we needed to add into Porter's model. So we did a lot of value stream mapping, we spoke to a lot of people, we worked with our consumers, we worked with our staff, we worked and looked at, so what do we do now? What are all those barriers? What are the things that we run into on a daily basis that don't make this system work? and what would you actually like to see? What would it look like if it were different? We also looked at how do we actually engage our workforce and what do we need to do with our workforce to actually make this different. This is change, and as we've heard 1,000 times today, change is difficult and it takes time. So what do we need to do with our workforce to enable that change to occur? Because this needs to be driven from the clinical level, it needs to be driven from the front line. So we added in a few things to Porter's model. This is the next edition of our value-based healthcare model, and it actually really defined what our model of care was about. So it's not only about the care that we provide at the Royal Dental Hospital of Melbourne, but it's also about the preventative care that we provide in the community, and that really upstream model around how do we actually prevent dental caries rather than actually treat it at the end of the day. So our model of care now is very defined around not only what we're going to do in the hospital, but what we're actually going to do from a prevention point of view. We refined some of our pieces of work and looked at it not just from a consumer point of view and how we engage in co-design with them, but we actually had done a lot of design and engagement with our staff as well. So we put them into the model so that they were clear about it was front and centre with them too. What does the next model look like? We're not sure. I think we are very comfortable in saying we don't know. Where we're at the moment, though, is we've actually started our proof of concept. So we've actually started our model of care at the Royal Dental Hospital of Melbourne. We've selected our general care patients and we've designated 4 chairs in general care to actually start this model. What we're doing at the moment over the next fortnight is testing all the pieces of work that we've done. So we're testing the risk assessment tools that we've developed. We're testing our information and communication for our clients. We're testing all of that over the next couple of weeks before we put real patients in chairs. So we're on the journey, but we have quite a long way to go. I'd like to now hand over to one of our consumers. As we said, we have co-designed all of this with our consumers and their involvement has been extremely important. So I'll hand over to Jackie to tell you how that feels for her.
So, as a proud Aboriginal woman, I just wanted to thank the elders on the land which we stand, and say thank you for also taking care of the culture. I guess that I'm one of many consumers that have been consulted in relation to this, but I wanted to say that it is very important to highlight the fact that DHSV have worked very hard to ensure that our voices were heard. I started out with a fellow health consumer, Rebecca, who's sitting in the audience, and we actually put our hands up for the IHF working group, which is an international development of oral health outcome indicators. What we didn't know when we signed up and were all gung-ho about it was that was going to be at very odd hours of the night, and that for some reason Friday nights and Saturday mornings at very early at 1 a.m. was really not an ideal time. However, we worked through that. And I think what I was most grateful for is the fact that it was a very steep learning curve, but it gave me a global perspective in relation to what the oral health outcomes are. And it made me think. It stretched me. I had to think about a lot of the questions. It also was a good chance to get our understanding of what value-based healthcare was about. The voice of the consumer and the value streaming mapping was another thing that the dental health services did, and they listened to us we had a consultative group that sits under the chair and the board and advisors, but they actually listened to us about talking to the right people, and we weren't the right consumers on that committee. We said you needed to get out and talk to a whole variety of people, and they did. They went and talked to homeless people who use the services. They went and spoke to refugees and people who'd come from a cold background. But they understood and made it work for them. Consumer training. Perhaps this is the key to engaging consumers well, and just like a garden, that when you water them, we flower. And that is something that we really wanted to put out there. The executive and the board have been so kind in sending us to conferences like this and allowing us to come back and tell them what we picked up as being something that rings true to us, something that we could see working for that healthcare system. And when you invest in people like that, we just tended to grow and grow and grow. Co-design. I think we use, and particularly in Australia, but particularly in healthcare, I note that we use this a lot, but this was truly, truly co-design. We came in as equal partners, and I think that is very hard to do. The power was shared amongst us. Our voice was valid, it was heard, and we each had a reason in knowing why we were there. Good co-design looks fabulous. So how did it make me feel? Well, I guess in this day and age where Tinder is done and you find a good partner by a quick momentary glance and then swiping left and right, I actually became a really true partner with the health service. And I guess for Dental Healthcare Victoria, it's good to be a good partner. I was valued. I was finding it hard to believe that I was being part of a redesign of a dental care system that I knew so many of my people would be using. And it allowed me to grow and other consumers to grow and go on to do better things. I felt valued. I felt like my voice was heard, but I also could see that I was designing something more for my community. And it was so nice to go back to my community and talk about what we were doing. I was proud to be working and building something together. It meant that instead of just being what I usually do, which is a carer to my uncle and aunt for most of the time who are on dialysis, I finally had something else to talk about, and that's really important. As a carer, you don't get to go out very often and you don't get your voice to be heard very often, so it was amazing to be part of this extraordinary co-design project. I also felt supported. And I think this is another thing and a key to why to engage with consumers. You need to make sure that they are on the right page. You need to brief them before they come to the meeting. If you want them to make a valuable contribution, you need to make sure that they're kept in the communication loop. And that's why I knew my voice was being heard. I got briefed, I had telephone numbers to ring. If I didn't understand, someone would contact me. So overall, I was very proud to be a part of this, but I wanted to thank my fellow consumers who are here today for their contribution, because I am only one of many who put together this. Is that it? Oh, I'm so sorry. I didn't realise I was the last of the last of the last. I am so sorry.
Well, thank you, Dr. Sobe and Ms. Susan McKee and Jacqueline Gibson for your excellent presentation. I think we are running slightly ahead of time, so probably one or two things may happen. One is that we'll have more time for questions and discussions. The other is that we may end up having more time to refresh ourselves before we go to the gala dinner, right? So the floor is now open. I would like to invite all the speakers to join me on stage for question and answers. If you have any questions, please make your way to the front where there are microphones in the center of the room. And when you ask questions, please let us know who you are and where are you from. Right, please be seated. This is my seat. If there's no seats, then I will go down to the to the floor. That's all right, please. That's fine. So they are making me to stand up instead of sitting down comfortably. Is there any comments or questions from the floor?
Hi, my name is Kathy. Hello, my name is Kathy Bell. I'm from Dental Health Services Victoria, but I'd like to ask Dr. Santiago a question. First of all, thank you for your presentation and congratulations on the terrific work that you're doing, the wonderful work saving lives. I wondered, you mentioned 10,000 children born every year with congenital heart disease, and I wondered, not knowing the birth rate in Colombia, it's hard to know whether that's high or low. Is that high or low? Does poverty play any part in that? And do you have, for example, rheumatic heart fever as a condition that's widespread in Colombia? And is there a role for prevention in any of the work that you're doing?
Thank you very much. And we have an institution that's well known in Latin America, and I think that we concentrate in achieving the results, especially through humanism. I think that this is a culture embedded in our DNA. Every person is encouraged to do that. We also have integrity, transparency, and clinical excellence. To do that is very important to have teamwork. Teamwork is I think, is very important. And I think that sometimes we need to align physicians, because if you don't align the physicians, it's very difficult to obtain clinical excellence. But I believe that formula that makes no distinction between one patient to another. And I believe the culture is very important to do this kind of work in our institution. As you know, we treat children and families. And I think that it's better to explain every patient how would be treated in our institutions, and I feel that this humanism that we have in our institution is very important for every children that we treat.
Okay, thank you. Any more questions?
Hello, my name is Stephanie. I'm a dentist and I work at Dental Health Services Victoria. My question is to the University of Utah. I was wondering if you could explain how you went about collecting the data and how you worked out the costings in relation to gathering that data.
Okay. So, sorry, I'm going to repeat this back. How we collected the data, and then what was the second part?
So how you worked out the costings.
Like allocating the costs?
Yeah,
okay.
Exactly.
So that's a great question, because when we started this, we had all these different systems, and all this data lives in different systems. Our medical record has a lot of data. Our financial data is in another spot, and then a lot of one-off systems. And so how we went about, all the data that we're using was being collected by an automated system, whether that was our EMR or our financial information. But essentially, we built an enterprise data warehouse where we pulled all of these data feeds in and tied everything to a unique encounter ID, and then based on those unique encounter IDs or the attributes of that encounter, we could report on it. In making that data usable is so important. But as far as the allocating the costs, initially we built a homegrown system essentially to do cost accounting. And we really relied on clinical expertise to build out to define to us the rules and the algorithms. So for instance, we take all of our labor dollars and we allocate all of those based on the timestamps we have of how a patient moves through our system. So your dollars will be allocated based on how much time you spent on a unit, and then we can say this is how many nursing labor dollars went to deliver this care. This is with supplies and labs and pharmaceuticals, everything was already tied to a patient, and it really was just bringing all that information into one system. So hopefully that helps answer your question.
Maybe can I follow up to ask Jeff a question, because it seems that you're certainly using a lot of data and you've been analyzing the data, but in driving your projects, you are actually engaging the doctors. And we know that working with doctors and pressing them to perform is something which is very difficult. So what do? Do you wear a mask to work so that you will not be recognized by the doctors?
Well, I think I was kind of nodding my head as you were talking about just that culture of having everyone with a shared mission. And that's really what we're trying to drive. A lot of the reports I showed, I'm never going to be in the position to show up and show these reports kind of, hey, you need to do better, you need to do this differently, because I don't have any of that expertise. So the idea is really, we'll build transparency around the data, and then as a system, we will create a culture where we want to do what's best for the patients, and we will use that data to improve continually. So having engaged physicians makes a world of difference for people like me who are just really there to facilitate improved care.
Okay, thank you. Any questions from the floor? Maybe I have one for Dr. Dutton, because you have developed this very useful and innovative app for gestational diabetes patients. And I think you mentioned about extending the application or commercializing the apps. So what have you done since then? Because obviously it's a very, very successful project that you have undertaken.
Yes, it is. We're very pleased with the first results, and that really is a work in progress at the moment. We've had agreement to look at how we can commercialise it so that it can become widely available, and that's just going through the processes. And this does take time, as you learn when you start looking at all of this. But we hope very shortly to actually at least be able to use it for all the women within our health service. As I said, it remains in conjunction with CSIRO, and it's been a wonderful opportunity to do this collaborative work. So we're just working very hard to move this forward at the moment, to be able to take this and make it available for women in Australia and elsewhere. We've certainly had inquiries from overseas about this as well.
Well, but talking about gender equality, are you going to extend your app to people with diabetes?
It's one of the things that's actually being looked at. It's technology that actually goes across a lot of illnesses. As I said already, it's been used for cardiac rehab here in Australia, especially for people who live in centres outside of major metropolitan centres, and also for patients on peritoneal dialysis, where it's been very useful from the point of view of their health outcomes and measures and their care.
Well, thank you. This session is about sharing and learning from very successful projects, and we have heard four, their gold winners. Now, you may not have questions, but if you want to share your successful stories, you can also do so. Any takers? Or it may be easier just to ask questions instead of sharing. Now, what about dental health service? Because your program is unique in the sense that it must be something very new to the whole nation, is it? You're the first one to really try to have this almost total solution to reach out and improving the dental outcome of so many of your eligible patients. So how did you start thinking about this? Because this is what is most difficult, is to have the concept behind driving all this quality improvement process.
It's a big question. It really was around acknowledging that we weren't serving the people who we were meant to serve as well as we could. And that wasn't because people didn't want to and that people didn't care, but we weren't being set up in a way that ensured that the clinicians could work to the top of their scope of practice and ensure that our patients had the best outcomes possible. And it really was an entire engagement process. I wasn't joking when I said if you stood still, we'd talk to you about it, because we're very passionate about it being a way of actually aligning all of the work that all the stakeholders want to do around better health outcomes for our patients. And I think another key element to it was recognising the need to shift the culture in the organisation to one that was really engaged in this process, and that was a parallel piece of work that we did. Do you want to add?
Okay. Probably everyone is eager to go for dinner or taking a rest. So maybe because I'm chairing the session, so I have the final say, right? And because today we learn about volume versus value, and of course we are now value-driven, and one of the keys to enhance value is we learn to reduce waste, and we haven't wasted any time. That's why we are able to finish in time. And with that, may I conclude the session? But thank you all, and thank you everybody, and thank you all the speakers.